Hello guys, this is Jonathan Munoz, and today I want to talk about congestive heart failure. Why? Because I want you to have the, the knowledge of how we do things in inpatient medicine for your rotations, for your observerships, for the beginning of your inpatient medicine year or rotations as a new intern. So you can get out of trouble or catch the eye of an attending if you're doing an audition. Now, I'm not saying that I'm perfect, I know everything there is about heart failure, but there are things that kind of are important to know, and many people that just start don't know. So just pay attention to what I say. If you don't agree, if you think there's more to it, it's fine, and there's probably more to what I do, but at least I want you to get the beginning points because you will be asked about this when you present these patients. Okay, so let's start with this. Patients with congestive heart failure will present to the ER with shortness of breath. Now, when interviewing a patient with shortness of breath, you have to make sure you have a differential diagnosis plan ahead. You make sure that you ruled out pneumonia, pulmonary embolism, myocardial infarction, true myocardial infarction. Why these three? Because all of them present with shortness of breath, but it's easy to differentiate them, right? The problem is that when the ER gives you the patient, they don't make the differentiation. They just say, oh, we put the patient on Lasix and antibiotics because there are infiltrates bilaterally and we cannot make certain that it is only CHF right now. He said that had subjective fevers at home. So that is your job. Your job is going to be, when you present to the attending, is that you're going to make those differentiations and treat the patient to what is the best that you think could be happening at this time, and forget about the rest. Okay, so that is first. The second thing I want you to keep in mind is, as an internal medicine doctor, hospitalist, or taking care of the inpatient medicine rotation, when you receive a patient, the discharge planning starts the moment you admit the patient. This is something that you hear all the time, but it's so true. You don't want to waste an extra day with things that you could have done at the beginning. Why? And keep this in mind, is that the attendings that you are working for, that's supervising your job, they are the ones that get the critics or the clapping for your work. So if you do a great job, they will get all the rewards of that. But if you do a terrible job, they will get all the critics of that, and then you will hear from them. So stay away from that and listen to me in this part. Discharge planning starts on the day of admission. If you can say one day that attending has a length of stay that is lesser than other attendings, and that will be because of you. So that is good. Or that attending could have a higher mortality record or score because of your good documentation. So it's not only all about just the patient and his clinical condition, but now it's also about the other things, the customer care, the documentation, the length of stay, mortality index, risk, what is called the case mix index or CMI. Very important to know. So if you can read about that, read on your own time. Okay, so you receive this patient with shortness of breath, you make sure there's nothing of those three, and now how do you confirm is CHF? So you know you have your BNP on admission, it's elevated 400, and you know you have bilateral infiltrates on the chest x-ray, because pneumonia is only unilateral, unless it's some terrible atypical pneumonia that can be bilateral, and it doesn't have fevers, and you have fluid overload all over the body. So now you explain all that. Now another thing to make sure you identify when you receive a patient with shortness of breath is if this patient on respiratory failure, any oxygen saturation below 88%, is respiratory failure, and it increases the mortality risk by so much that your case is, in paper, your patient is super sick. So we will talk about that, but okay, so it's important to make sure that you can convey that your patient is super sick, you receive a terrible patient, and you're doing your best to take care of this patient. It's important to note that in documentation. And you only do that by adding diagnoses that support that thinking. Okay, so we agree that this patient is congestive heart failure exacerbation now. So it's a new patient, so you don't have any records, you don't have any echocardiograms for the past. So your first diagnosis is acute congestive heart failure exacerbation due to medication non-compliance, illegal drug use, dietary indiscretion. Remember those three, because this is the way we talk about them. It's only any of those three, or myocardial infarction. 4. Okay, so you link the diagnosis to one of these, and then you say unknown ejection fraction at this point. Why is it important to say unknown ejection fraction at this point? Because the billers, the coders, are looking for that piece of information because it makes a difference for them. So at this point, you just write that part. Now, what is your next line on that part? The first diagnosis is differential diagnosis that you went through. I believe that this is unlikely to be pneumonia due to the absence of consolidation, fever, negative procalcitonin. And I also believe this is unlikely to be pulmonary embolism because of a negative D-dimer or a CT angio of the chest with contrast that was negative for pulmonary embolism. So you have to mention your differentials to make sure that the attending knows that you thought of possible life-threatening conditions. Now, next part is what is the workup that you're planning to do to continue working up this heart failure. So you're going to order an echocardiogram, you're going to order morning labs for the next day, CBC and BNP to monitor electrolytes because you're going to start diuresis, and you're going to get troponin trends ×3. Why? Because another thing that could trigger an acute exacerbation of heart failure is an acute MI. And many times you will find that patients with acute heart failure exacerbation have at the same time an elevated troponin, mildly elevated, but the ER always calls those NSTEMI, and it's not necessarily NSTEMI. You shouldn't call any troponin elevation NSTEMI, but identify if there is a triggering factor for that troponin elevation, like sepsis, congestive heart failure, acute kidney injury. In that case, this troponin elevation without acute signs of anginal symptoms, it's type 2 demand ischemia, which explains the troponin elevation. And remember, in medicine, in this rotation that you have to explain every finding on the laboratory results, on the physical exam, or the history. So you have to explain that. And if it's not NSTEMI, you have to mention this is very likely to be a type 2 demand ischemia because the hypoxia that this patient is presenting. Okay, so we have diagnosis number 1 is acute congestive heart failure. We went through the differential diagnosis, workup, and plan of treatment. So you're going to do plan of treatment. Basic for any patient on acute distress is diuresis with Lasix IV TID. I like to do it 40 milligrams IV TID if they're below 80 or 75 years old, and 20 milligrams TID IV if they are above 75 years old. Just my preference. There's nothing written. Some people like to do continuous infusion of Lasix. You can do that. Some people like to do metolazone, but I stick to what I know, which is Lasix IV for acute presentations, and then Diagnosis number 2 will be acute hypoxic respiratory failure because the oxygen saturation is below 88%, the patient is in 4 liters, and this is likely due to congestive heart failure exacerbation. Problem number 3 is troponin elevation. Rule out NSTEMI versus type 2 demand ischemia. You're going to rule out that. Read more about those two. And let's leave it at that. Okay, so first day you start with that, start treating and get the echo. The echo comes with an ejection fraction of less than 45%. What do? Less than 45%, we're talking about systolic heart failure, and this needs for you to rule out what? Occlusive disease. So you have to make sure you call a cardiology consult or add that to your plan, communicate that to your attending, to your supervising resident. Hey, this patient has systolic heart failure with an ejection fraction of 30%. I think we should call cardiology to rule out any coronary artery disease. So you call one and they interview the patient, and if the patient is not using methamphetamine, which is usually a triggering process for congestive heart failure, that's systolic or cardiomyopathy, then they will try to look for more ischemic workup, which at this point means angiogram. So it's for the cardiologist to do an angiogram. Now you can also call a cardiologist for your diastolic heart failure if that's what you feel is better. I think at your starting point of being an intern, you should call cardiology, but it's not wrong to call cardiology. It's nothing bad about calling cardiology, but when you present the patient, you have to talk like you know what's going to happen. Like you say, I'm going to start this patient on Lasix, and based on his response, I will start him on guideline-directed therapy for heart failure exacerbation, diastolic type. So you could as well start him on the first day on a little lisinopril, on a little beta blocker. And so you get your echo, you call cardiology. The next day, your progress note of the day, it starts with the subjective part of how much output this patient had on the last 24 hours. What is he currently on, the amount of Lasix that he's running? And how is he feeling? Is he still short of breath? Is he still on oxygen supplementation? What happens if you stop the oxygen? And does he become hypoxic again? Because if that is not happening again, then he's improving. And that's what we want to show on every progress note, that your treatment is working. So you want to try to show some improvement, but there's no improvement. You just show that there's no improvement and talk about it, because there might need something to be adjusted. Okay, so you talk about those parts first on the subjective, and then you go to the assessment and plan, and you change now that you know this is diastolic. So it's problem number 1 is acute congestive heart failure exacerbation due to dietary indiscretion, diastolic type. The other problems remain the same treatment. Now that he has tolerated ACE inhibitor and he has tolerated your initial dose of beta blocker, and this is a diastolic type, you could increase the beta blocker if the heart rate is still above 60s, 70s. You could still increase a little more. I like to use metoprolol tartrate, starting on 12 and then 25. Hopefully by discharge I get the patient on 25 or 50. But anyway, on day 2, he's improved. You have increased the doses. You could say, oh, he's improved. I want to do one more day of IV Lasix because he still has some edema on his lower extremities. But tomorrow we'll move into PO. And the next day, your next progress note is also mentioning early that this patient can walk, can eat, and is tolerating medications well. Why? Because if he continues to improve, you want to prove that you have thought of everything that is needed for this patient to go home, like ability to walk, ability to eat, and ability to take his medications. Why? Because if he's not able to walk more than 20 feet, or he needs maximum assistance to get up from bed and walk, and this is not something that he was doing before, then he may need to go to a skilled nursing facility. And if you can arrange that or foresee that this will be needed, on day 3, you may have this happen on day 4 instead of noticing this on day 4 and waiting for this to happen on day 5, or if it happens on the weekend, not happening at all. So remember, attendings, we like to discharge our patients safely, and if you can prove that you have thought of everything that is needed for me to discharge a patient safely, then you're in a good position. Okay, hopefully you like this video. It's just for you to keep in mind when doing your rotations in internal medicine or the inpatient care rotation. Hopefully you like it. Thank you for subscribing and keep following for more videos.